Hello, I'm Raghu Kaluri from Columbus, Ohio, and I'm going to talk about role of endovenous ablation and venous reflux. This is my disclosure. So, when venous disease presents in its chronic form, it could present as varicosities in the great saphenous vein, small saphenous vein, anterior accessory saphenous vein, or posterior accessory saphenous vein. Sometimes non-saphenous veins indicative of probable pelvic cause are also seen, and these usually arise from the mid to lateral aspects of the inguinal ligament. Venous disease can also present with skin changes such as venous eczema, skin thickening, etc. And ultimately, venous disease can also present with venous leg ulceration. The 2020 appropriateness criteria from AVF suggest that the role of great saphenous vein ablation in patients with C2 through C6, if they are symptomatic, meaning presence of varicose veins or swelling or skin thickening or ulcers, and they demonstrate great saphenous reflux with or without saphenofemoral junctional reflux, it is appropriate to treat these patients with endovenous therapies. Similarly, patients who have advanced disease from SEEP classes 4 through 6, ablation of great saphenous vein below the level of the knee is also considered appropriate. However, caution should be exercised in patients who have minimal symptoms and have only below knee great saphenous vein reflux. The AVF recommends looking at other causes of edema, such as elevated central venous pressure, obesity, or calf pump dysfunction. Let's start with the most severe form of venous disease, the venous ulceration, and it is important to discuss the landmark randomized controlled trial, the EVERA trial, which randomized early ablation to deferred ablation. In patients who had early ablation, they demonstrated faster time to heal, more ulcers were healed at 24 weeks, and this cohort had more ulcer-free time within the 1 year. When you looked at the patient-reported outcomes such as the VCSS score, the E5QD, SF36, all of these improved in both groups, but the early intervention fared better than the deferred group. When you look at the types of interventions done, it was not just thermal ablation. Regardless of what endovenous therapy was used, there was improvement in these patients in both cohorts, earlier and deferred groups, but the earlier group fared better. Now that we know that any of these therapies work in improving the worst form of venous disease, let's talk about the therapies that are available to eliminate reflux. When you look at the saphenous veins, meaning the straight axial veins, we have thermal technologies, also called as TT, and non-thermal, non-tumescence technologies called the NTNT. TTs are radiofrequency ablation and laser ablation, and the non-thermal technologies are cyanoacrylate, mechanical-chemical ablation, and microfoam ablation. Obviously, surgical stripping is still used in a very small percentage of patients. So what about endothermal techniques? Now, endothermal techniques are now pretty old. Radiofrequency ablation was approved 22 years ago, and laser was approved 18 years ago, 4 years after radiofrequency ablation. And both of these show very high success rates in the range of 95+%, and their longevity is also well known in terms of the durability of the procedure, up to 5 years. The first non-thermal, non-tumescent ablation that we're going to discuss about is the cyanoacrylate treatment, also called the Venous treatment. This is now a Medtronic product. What it entails is injection of cyanoacrylate glue through the course of great saphenous vein in small aliquots, and dragging back the catheter without any need for tumescence and collapsing the vein. As simple as that. The primary endpoint of complete closure was seen in 100% of the patients in the randomized control trial at 3 days, 1 month, and then the non-inferiority trial demonstrated that the venous seal was not inferior to radiofrequency up to 36 months and now up to 5 years. The next non-thermal, non-tumescent technique is Claravane. This is essentially a little hockey stick type of wire that rotates at specific speed, and then a sclerosant in its liquid form is injected as the catheter is advanced back, and this helps denude the endothelium and cause sclerosis of the vein. Now, when you look at the data on this, there are certainly more number of papers that are published by this technique, also called as MOCA. And as you can see, the success rates are pretty high, up to 95% in the great saphenous vein, 94% in small saphenous vein, and these could be done with relatively very little pain because the tumescent anesthesia is not used in these two techniques. The final non-tumescent non-thermal technique is Microfoam, also called Varithena. Now this is a Boston Scientific product. This is a 1% Polidocanol solution constituted into foam with a very low percentage of nitrogen, and the foam is directly aspirated from the canister and injected into the vein. Vanish 2 is the trial that tested Varithena in varicose veins. The primary endpoint in this trial was rather interesting. It was improvement of clinical symptoms based on a VV-SIMQ score, and the trial reached the endpoint of 80%. The downside of Varithena or Microfoam that people are concerned about is the slightly increased risk of DVT in these patients. Although in real world the risk of DVT may not be as high as the ones reported in the pivotal trial of 7.2%. So this is a reasonably good therapy as well. What about the non-saphenous veins? The treatments that are used for non-saphenous tortuous veins are phlebectomy, foam sclerotherapy, or foam-assisted phlebectomy, which I will talk in a little bit. And sclerotherapy, whether it's in foam form or liquid form, whether it's visual or it is under ultrasound guided technique. The goal of phlebectomy is to remove those larger varicosities and tributaries. The classical technique described is making the patient stand and mark the vein either as a train track on the sides of the vein or directly over the vein, and then go with small incisions and try to externalize the vein. Foam-assisted phlebectomy is a slightly modified technique where the veins are identified under ultrasound, and very small concentration of polidocanol, typically 0.5% polidocanol foam, is injected into the vein, making the vein opaque under ultrasound. And then tumescence is actually given under ultrasound, compressing the vein from outside. The foam spasms the vein from inside, and then under ultrasound guidance, the incisions are made and the hooks are passed, and you can see the hook grabbing the vein, and then we exteriorize it. And as you can see, most of these end up with blood loss of less than 5 cc's, since the vein is intensely spasmed with tumescence on the outside and foam on the inside. So when you look at all of these therapies, you got to pay attention to the patient as a whole. Regardless of what technique you pick, we have to make sure that the patients are not morbidly obese. Patients who have concomitant peripheral artery disease, especially those with the infrapopliteal disease, because even if the great saphenous vein is refluxing, as long as it's not extremely enlarged, it makes a very good conduit to cross the knee on the arterial side. So always think about the iliocaval obstruction. Make sure that what we're dealing with is not post-thrombotic syndrome or iliac vein obstruction syndrome resulting in secondary varicosities. Pain from other sources are also important, such as lumbar degenerative disc disease, complex regional syndrome, and all those type of things, which will not improve if not get worse with especially multiple needle sticks that are required for tumescent-based techniques. Edema from other sources are very important. So final thoughts on this topic: laser and radiofrequency will remain the market share because most of us have been doing it now for close to a decade and a half to 2 decades. Non-thermals, there is no head-to-head trial. Cost implications, when you look at non-thermals, there's no generator required. It comes in, all non-thermals come in a regular kit, but the expense of disposals is higher than that of the thermals. So, finally, cyanoacrylate is useful in those patients who have needle phobia, who don't want to wear socks. Both legs need to be done at the same time because they're busy. Elderly patients who are at increased risk for ecchymosis or skin tears or thermal burns, those with bleeding concerns, patients with phlebolymphedema when you don't want to have thermal injury to the saphenous chain of the lymph nodes. This needs to be avoided in patients with prior allergy with cyanoacrylates. We have to consider patch testing for some of these patients if they insist on it. Should be avoided in subdermal and very superficial veins because this is an implant and the patients will feel it under the skin long term, which is not a good sensation to have. When you look at mocha, I personally have not done it yet. Seems like a potentially good treatment option, but similar to glue and just like thermal technologies, you need a straight vein for the wire to be passed. It's a good technique in phlebolymphedema patients. The amount of sclerosant you can use in any given setting is a limitation, so doing multiple limbs at the same time like cyanoacrylate treatment is quite difficult. And as the wire rotates, some people have had the wire stuck to the vein wall, and there's one report of externalization of the varicosity, the great saphenous vein. So that's one of the downsides. When we look at microfoam, again, this takes care of the veins. It's perfect for those tortuous varicosities where you could put tiny 4 French or 5 French sheets and inject foam. Best for those post-thrombotic scarred veins or neovascularized veins, partially successful ablations where you can't pass the wires, etc. Those patients who have bleeding concerns from extensive needle sticks, this is a very important technique. Extensive lipodermatosclerosis where you can't do tumescent anesthesia, this is a good technique. Again, it is a non-thermal technique, so in patients with phlebolymphedema, if I'm worried about worsening their lymphedema with thermal techniques, I would do non-thermal techniques in those type of patients. With that, I end my talk. Thank you.